So good evening and welcome everyone. And thank you for joining us. So if you haven't met me before, my name is Mark Taylor and I'm privileged to say that I'm the Dean of WashU Olin Business School. And I'm delighted to be kicking off the first Leadership Perspectives event for the new academic year. As a top business school, we believe it's important to contribute meaningful thoughts to the marketplace of ideas with this series that brings you to the gateway of ideas, innovation, inspiration with informative and timely speakers and events. And this evening, we have some very timely speakers and some interesting events. We are indeed very fortunate to be joined by WashU's Chancellor, Andrew Martin, and WashU's infectious disease expert, one of WashU's infectious disease experts, Dr. Stephen Lawrence of the WashU School of Medicine. And in just a moment, we'll hear from them about WashU's response to the global pandemic and what's on the horizon here at the university and beyond. But before we get started, let me briefly explain today's program format. So we'll first begin with some thoughts from Chancellor Martin and from Dr. Lawrence, and then I'll join in again as we have time for a question and answer session. And if you'd like to submit a question, please use the Q&A feature, which you should see on your screen. Okay, now it's my very great pleasure to introduce our guests. Andrew D. Martin is Chancellor of Washington University in St. Louis and a Professor of Law and Political Science. He's the former Dean of the College of Literature, Science and the Arts at the University of Michigan. Dr. Martin's expertise is in the study of judicial decision-making, with special emphasis on the US Supreme Court, as well as the lower federal courts. He also works extensively in the field of political methodology and applied statistics, and he's published in leading social science and applied statistics journals, including the top international journals such as the American Political Science Review, the American Journal of Political Science, Political Analysis, the Journal of Legal Studies, and Statistical Science. Dr. Martin is a frequent presenter at conferences and workshops throughout the country, throughout the world, and his research has been supported by the National Science Foundation, the MacArthur Foundation, and the National Institute of Health. And he served as principal investigator on 8 grants from the National Science Foundation, was elected a Fellow of the Society of Political Methodology in 2012, and received the Distinguished Faculty Award from the Alumni Board of Governors of Washington University in 2013. Dr. Martin received his AB from the College of William and Mary, cum laude, and with high honors in mathematics and government in 1994. And he received his PhD in political science from Washington University in 1998. And he's previously served as the Charles Nagel Chair of Constitutional Law and Political Science at WashU, indeed in the School of Law, and as Vice Dean of the School of Law, as well as being founding director of the Center for Empirical Research in the Law and chair of the Department of Political Science in Arts and Sciences. And we're very delighted to have Chancellor Martin with us this evening. Dr. Stephen Lawrence, our second guest, earned his medical degree from Washington University School of Medicine in 1997, prior to completing his internal medicine residency at Barnes Jewish Hospital in 2000 and his infectious diseases fellowship training at the School of Medicine in 2004. He subsequently also earned a Master of Science degree in epidemiology from the London School of Tropical Medicine and joined the full-time faculty of the Infectious Diseases Division in 2005, where he is now Associate Professor of Medicine. Since 2000, Dr. Lawrence has been actively engaged with preparedness, education, and response to infectious disease threats, including the 2001 anthrax letter attacks, the 2009 H1N1 influenza pandemic, the 2014 Ebola outbreak, and of course, COVID-19. for which he served on numerous medical school, Danforth and public health agency task forces. Dr. Lawrence is also Assistant Dean for Curriculum and Clinical Sciences within the Office of Medical Student Education and the co-director for the Medical Student Infectious Diseases course. His research interests include influenza and other respiratory viral illnesses, vaccines against viral illnesses, and infections in transplant patients. And he sees patients and supervises trainees in the infectious disease outpatient clinic and on the infectious disease consult service in Barnes Jewish Hospital. I should also add that Dr. Lawrence is no stranger to the Olin Business School, as he is a frequent speaker at our twice-weekly Olin Town Hall meetings. I will now hand the floor to Chancellor Martin and Dr. Lawrence, their discussion.
Well, thank you so much for that kind introduction, Dean Taylor. Thanks for inviting Dr. Lawrence and me to talk a little bit about the university's response to COVID-19. Dr. Lawrence and I are going to go back and forth a little bit and talk about a number of things, but we really are interested in getting to your questions. So make sure you put those in the Q&A function, and we'll make sure to save plenty of time to answer questions about just about anything. Here's what we'd like to accomplish, though, in the dialogue we're about to have. We're going to look back to really the beginning of this calendar year and do a little level setting on what happened at Washington University over the course of the spring, the summer, and now into the fall. I'm going to talk a little bit about the values that we use to guide the process that the university engaged with. We're going to spend some time talking about the budget of the university and how our finances have been affected by COVID-19. And then we'll talk about the fall planning process, where we are today, and what the future might look like. So let's start at the very beginning. And I'd ask you, Dr. Lawrence, to start at the beginning. When this virus was first traced in China, when did you learn about the virus? And at what point did it begin to be something on our radar and affecting what we were doing at the university?
Well, thank you, Chancellor Martin, and thank you, everybody, for the opportunity to talk about this. This has obviously been the topic of discussion for the last 6 months, but this really all started in January. And I keep an eye on something called ProMed Mail, which is a listserv for epidemiology, infectious disease nerds like myself, who then just are tracking what might be that next big outbreak. And then in January, we really started to see in early January that there was this new virus that was affecting some parts in China. Very quickly was determined to be a coronavirus, which was of concern because we've seen some outbreaks with SARS in 2003, which could have become a major pandemic. And then the Middle Eastern Respiratory Syndrome virus, or MERS, in like 2013, and it caused severe disease. And so when we see a new coronavirus, it raises some concern. But, in the early stages, you just see a few cases, and many of these signals die out. But in this ProMed Mail, we really started to get a signal that it was getting big. And then there were large clusters. And then you were starting to talk about hundreds and even thousands of people being involved with outbreaks in China. And as we know in today's world, because everything is international, can travel globally very quickly, a viral pathogen that emerges is almost impossible to contain if it's highly contagious between people. And so by February, that very much became the case. We started to see then widespread disease starting in Europe, and that really prompted us to start planning for it by the end of January, saying this is something that's likely going to come to St. Louis, it's likely to come to our community, and to start putting the planning in place. And so Chancellor Martin, at this point in time, what was happening to prepare at the administrative level at WashU?
Well, in terms of my office and the leadership of our schools and colleges, I think this was put on our radar in February. I think the very first thing is when we had some students that were studying in China in January that we needed to repatriate. But it was something that we were looking at, and of course we were all hopeful that this wasn't going to affect us here in the United States and not affect our operations. By the end of February, it became clear that this was something that required a great deal of attention. And I remember the dates very well. It was February 27th and 28th, where we put in place a crisis response structure to be able to deal with the pandemic. And it's complicated because of the many things that the university does. I mean, you think Washington University, of course, you're thinking about education and research, but of course, we're also in the patient care business, along with our partners, BJC Healthcare. And this was going to have profound implications on everything: research, education, and patient care. And so at the end of February, we stood up a crisis response structure. One for the Danforth campus, led by Rebecca Brown, my chief of staff, and at the medical school, led by Paul Scheel, who runs our faculty practice plan, to manage crisis response on the two campuses, all of which being supported by Emergency Operations Center, which was being coordinated with BJC. So we put that structure in place at the end of February, and those were very fraught times. Now, there hadn't been a case yet in the state of Missouri at that point, but we had to put the structure in place. And then beginning that same week in February, we needed to start pulling back some of our students who were studying abroad and begin to restrict travel among our faculty. So we started by bringing study abroad students back from level 3 countries, which was Italy, and then a few days later, if I recall, Spain and France, and then all of Europe, and then everywhere. And we asked all of these students to return to their permanent residences. Now, we had 2 students whose permanent residence was China, and so they returned here to St. Louis, and we took care of them. Thankfully, only a few of those students studying abroad came back and were positive, and none of them, as far as we know, were hospitalized. March 7th was our first case in St. Louis County, which was an undergraduate student from another institution who was studying abroad in Italy and was repatriated back to the United States. So that first week of March, which also happened to be the week of my board meeting, which we invited Dr. Lawrence at the very last minute to come talk to our board about the disease and what we were likely to see play out over the next few weeks and months. Dr. Lawrence, you remember how stressful those times were, both here at the university, but also in the region. Can you tell us a little bit about how you and your colleagues were called to provide guidance, not only to university leadership, but also to our political leaders here in the region and the state?
Yes, indeed. Those were very challenging times that we'll never forget. And one of the things that was so striking about it is how rapidly everything was changing, almost on a daily basis. That there were new information that required changes in how we think about the virus and where it goes. But in our division, we have a group of people who have been thinking about this and are really trained to deal with this kind of event, and have. Certainly nobody in the country or in the world has seen something like this since the 1918 flu. So nobody has a lot of exact experience of something of this magnitude, but certainly we have been trained to be able to handle these types of things. And so we were really rapidly deployed in 3 major areas: one, to support the Danforth campus and to help and help to make sure that the campus remains as safe as possible. The other one is a large group of us were working in the hospital to try to get the hospital ready as far as having all of the supplies that are needed, the protocols that are in place to be able to handle a large influx of really sick patients and to prevent transmission within the hospital setting. And then regionally too, we've had a long relationship of collaborating with and supporting our local public health partners, and this was no exception. We have been, from the beginning, active participants in giving advice to our health departments, and also being ready to provide support when specifically asked. And so one of the manifestations of this then was the creation of the Metro Pandemic Task Force, which was really designed to pull the health systems together and the universities and the health departments to be able to have a unified front to ultimately what we call flatten the curve. Because what had been seen in Italy at this point was very disturbing. There were very high case levels to the point where they were overwhelming the hospitals. And not only does it mean a situation that there's so many COVID patients that are really sick, you can't take care of them, but ultimately other patients with conditions like heart attacks and strokes that are very treatable weren't able to get care either because the capacity was so strained. And so that was the situation that we were trying to avoid by both public health measures and hospital preparedness. And really that's where we went to work right away.
Great. So let me pick up the timeline and come back to where we left off, which is the first week in March. And I remember that over the weekend we had in that first weekend of March, we had our first positive case in Missouri, and we were constantly updating the data, sharing data across the two campuses. Of course, WashU Olin is an institution that prides itself on being data driven. I'm a data scientist myself, and so the data that we had was pretty limited. We got the best data that we possibly could, but we were making decisions under a lot of uncertainty. And we were faced with a particularly challenging problem. Our challenging problem is our spring break for our Danforth campus students was the week that began on March 9th. And so we had thousands of our students who had left the campus and have gone to all corners of the United States, some internationally, and in some of those places that we were experiencing very significant community spread. No community spread in St. Louis at the time, but we had to make a decision about what was the right thing to do for our students at this moment in time when we didn't even have a case yet. There were lots of conversations, but ultimately on Monday, March 9th, we reached the decision that we were going to ask our students not to come back from spring break. This was a very unpopular decision. Lots of people thought that we were overreacting. It's like, there's one case in Missouri. What are you doing? Well, the rationale for the decision, and actually once we got into our values, the decision became pretty easy, is that it was important for us to protect the health and safety of our university community and the broader St. Louis community. And given that we had students that were in places where there was community spread, it was just fundamentally irresponsible for us to encourage them to get on an airplane or get back in their cars and return to our campus, even if they were just coming to pick up their items. And so Wednesday, March 11th, we made the announcement to tell our students, do not come back from spring break. No, you can't come pick up your things. We're going to give you an extra week of spring break and you're going to continue education online. One of the things that we did that I was really proud of is the tail end of that week, we organized a pack and ship operation for all of the essential academic materials at our cost for the undergraduate students that were living in our housing. And the following week, between Monday and Thursday, we sent over 2,000 packages of materials to our students so they could continue their academic pursuits. It was a logistical miracle, actually, that some of our colleagues led us through. And we had hundreds of volunteers who were picking through our students' dorm rooms, grabbing the materials the students asked for, and shipping them on. At the same time, our faculty and staff needed to prepare for online instruction, which is something that but for a handful of programs, including some programs here at Olin, is something that we hadn't done a lot of. And so really over the course of a week and a half, we were able to stand up what we needed to be able to do education online. The following week, the week that began on St. Patrick's Day, was the week that we decided that we needed to dramatically change operations at the university, that we couldn't have people continuing to come into the offices. My office here in Brookings Hall closed on Monday, March 16th. By March 23rd, we had really ramped down operationally to only having essential workers, and that's true on both of the campuses. So Dr. Lawrence, can you maybe tell us a little bit about what was happening at the medical school during this period throughout the month of March?
Sure, and I'd also just add, being involved with the Danforth campus decision-making during this time, it was just remarkable how quickly big decisions were made. I found it, coming from the medical school campus, just a very eye-opening experience about how quickly some of those big decisions that you just described can be made very decisively, and again, based on, on the values that we were trying to uphold. And on the medical school side of things, the big concern at this point was, again, just trying to do what we can to prepare for and to prevent the worst case scenario of a collapse of the healthcare system. So in a lead up to preparing for an influenza pandemic, we've always been aware of what we called a situation that would lead to altered standards of care. And that would be an instance where, to boil it down in a simplistic term, say there are 20 people with respiratory failure and they need a ventilator, but you only have 10 ventilators and you only have 10 ICU rooms and you only have 5 nurses. So you would run out of staff, stuff, and space. And it takes drastic measures in a large pandemic to be able to prevent that from happening. So in anticipation that that could happen, we instituted a very draconian measure of canceling elective surgeries. And that is something that certainly what it does is it frees up a lot of the resources, the hospital beds, the ICU beds, the ventilators, and all the staff. But it's also not something that is ever taken lightly because of the massive impact that has on the medical school's finances. So this is a last measure event. These are the contingency plans that we've had in place as what you would use for that situation, but had never really been deployed. So that's a first time where that extent of canceling of those surgeries occurred. And this was still, again, very early, but in anticipation of what could happen, because right around that time, March 18th was when there was the first death in Missouri related to COVID-19. And then the next day or a couple days later, we started to prepare the lofts and the night center to be able to house healthcare workers who are working in the hospital who needed a place to go in case they couldn't go home to their families because of potential exposures. And then just a few days later, just to show how quickly things were changing, that it went to on the 23rd is when the stay-at-home order was issued. And so all of these things have massive impacts. And certainly I mentioned the impact of the medical school finances, but Chancellor Martin, certainly that had to have had a very large impact on the financial institution or the resources of the university. And so how were those factored in?
Yeah, we're gonna dig into that. I mean, as I think about what was happening in those times in March, I mean, we were, and this is true across the university. It's certainly true at the medical school, but here on the Danforth campus as well. We were moving incredibly quickly in a very dynamic situation, and we knew that there were going to be really profound financial impacts. And we were also in a situation that we really couldn't take the time to do much planning. We were able to turn to planning in early April, and we'll get there in just a second. But there were some things that we needed to do right away. First of all, there was just a lot of fixed costs on both campuses in order to be able to just continue operations. And we made the decision very, very early that we were going to do what it was necessary in order to continue operations. So that pack and ship operation that I mentioned of our student materials, we made the decision to do that. I think it cost us about $1.5 million in terms of shipping costs and so forth. But we were just like, we have the depth of the financial bench to be able to handle these things. And so whether that's obtaining PPE over at the medical school, whether that's staffing up in particular areas, we were just moving as fast as we could. It was also the case that we knew we were going to have some very significant budget shortfalls along the way. And so at the end of March, we announced a hiring freeze on the Danforth campus and in what we call the central fiscal unit. And the medical school had already put in a de facto hiring freeze at that point in time. We had been hearing from our students, on-campus students and off-campus students, that there were some students in really complicated financial situations because of housing displacement and the like, parents losing jobs and the uncertainty. And so we stood up a crisis response fund that opened on April 1st, and we secured over $750,000, which we distributed to over 700 faculty and staff who had emergency needs. We've just completed another tranche of that fund just this week to support our students who were particularly challenged. We also made a decision, which I think is one that I'm really proud of, is that for our students that were on financial aid, I mean, obviously that we could have not refunded their room and board because we had provided them their room and board. We went ahead and charged their student account, put the money back in that we would have spent for their room and board, such that they had those access to those resources to be able to get them through the last couple months of the semester. So it's March. We have, over the time of just 3 weeks, have gone from a regular operating Danforth campus to one where all education is online, very few employees are on the campus, and we're housing about 300 or 400 students who are unable to travel back to their homes. And then on the medical campus, right, we had wound down research, other than to some essential research and obviously COVID-19 research that we continued. And the medical school, in terms of the clinical practice, had been radically changed in just over a three-week period. So Dr. Lawrence, can you go maybe a little bit deeper into some of the things that our team, WashU Medical School, but also with our partners at BJH, what the things that we were doing in order to prepare not only in the hospitals that we work in, but in the hospitals in the region?
Yeah, so certainly within the hospitals that we worked in, that we were very much preparing for a large surge, and that included a number of different activities, including trying to obtain all of the personal protective equipment, or PPE, that we could to be prepared in case we needed it, to put into place actually things that had never been done before, but to find ways to reuse some of the PPE that was meant to be disposable. There were also changes in where patients were taken care of. We turned some units into COVID units so that that's all they were, one place where there were only COVID patients being taken care of, and entire floors that were just repurposed, specifically for this. We turned entire floors into negative pressure ventilation relative to the adjacent floor, so that it could serve as a place to be able to take care of more critically ill patients and keep the virus contained. There were changes that, to help conserve that PPE by, we had to stop our in-person clinical learning for our medical students. Our clerkship students, those in the third year and fourth year who are taking care of patients, were asked to leave the hospital while all of this was going on, partly to just limit the number of people in the hospital and the use of that PPE for those frontline healthcare workers who are really taking care of it. And then we also were involved with coordinating the region with the Metro Pandemic Task Force, and this conglomeration of the major healthcare systems that for unprecedented, this really was unprecedented in sharing information, creating an IT infrastructure to share data that it said, okay, so BJC and SSM and Mercy, they're all sharing this data to be able to say, what are you seeing? What are you seeing? How many beds do you have available? What's your ICU capacity? So that there was this regional response that was able to make it more effective, able to help shift where patients were going if needed, so that if one place had more PPE than others. And luckily, so we were preparing for the worst, which is what you need to do. And we did get to a point where it was getting a little bit scary in our hospitals, but it turned out that we didn't quite hit that capacity or exceed that capacity that would have led to the point of what we called altered standards of care. Thank goodness. But at that point, though, that this was, it took a little while before we realized that we were going to escape that worst of outcomes.
Well, yeah, thanks for sharing that. So to pick back up the timeline, so now we turn to the month of April, and there was a lot of very quick decision making, a lot of transition across the university. And in early April, I was able to take some time and to get together with my leadership team, and for us to spend some time thinking about what our values were. We knew that we were going to need to pivot pretty quickly into the looking carefully at the university's finances, to look at all aspects of our mission, education, research, and patient care. And we thought it would be useful for us to sit down about what are the principles that we would be using to guide these really difficult decisions. And so I want to just share what those were. First is the safety, security, and well-being of everyone. Not just of the university community, but the community in which we live. And so as we made decisions about classrooms and meetings and checking in on one another and everything else, it really was about centering well-being as an important principle. Second is our mission. I think it's really important for us to remember that what Washington University is all about is education, research, and patient care, and that we do those things to improve lives in service of the greater good. And so as we began to think about things, it was not so much what are the parts of our mission that we can put on hold. Rather, it'll cause us to think about what are the ways in which we can continue to advance our mission given the constraints that we were operating under, and at this time, a very set of uncertain constraints. Third, the mission caused us to focus on lives, not on campus, but also in St. Louis and around the world. And we really tapped the expertise of our colleagues in the infectious disease division, in the Department of Medicine, and our public health colleagues to not only think about how this is playing out in St. Louis, because that was so relevant and germane, but also thinking about how it's playing out around the globe. And we have lots of partnerships, research collaborations, and so forth that were global in scope. Obviously, diversity, equity, and inclusion are always important, central to how we run and operate the university. And we were learning very early on that this crisis was affecting individuals from varying backgrounds with varying levels of severity, particularly here in St. Louis and North City and in North County. And so it was important for us to keep in mind that some of the choices that we were making as an institution, particularly on the patient care side, really needed to have the social context of what was happening at the fore. Innovation, adaptability, working collaborative across groups and across parts of the university was also very important. Accountability and transparency are certainly things that I hold as essential to my understanding as leadership. And what was so hard about this is that we were being as transparent as possible in a very uncertain environment. And it's really hard for leaders of organizations when the people who work with you have really great questions and the answer is, I don't know. And so what we did is we committed to communicate as much as we knew, as soon as we knew it. Dean Perlmutter at the medical school, me here on the Danforth campus, and our provost and our deans were communicating a lot. And we had to communicate a lot because it was such a dynamic environment. Finally, stewardship and sustainability of resources is an important value. Washington University can only serve its mission if we do so in a financially sustainable way. And so it was important for us as soon as we could, really beginning in the first week of April, for us to look at our resources, to look at the budget, and to really drill down on some of the things that we needed to do.
Yeah, and Chancellor Martin, these values absolutely helped to shape all of the response from here on out, and they really were provided guidance to make sure that those decisions were made in light of what we were trying to accomplish within those values. And many of these big decisions that were really big ones that were on your shoulders, certainly some of them were related to some of the finances. And you mentioned something about the hiring freeze earlier. And then, what other types of implications then did that have? What were those other big decisions that had to be made that were made using those values to help guide those?
That's a great question. So let me take a step back and talk a little bit about what I'd call the business of Washington University. We're at a WashU Olin event, and so let me talk a little bit about how the university's finances work. So we're on a fiscal year that begins on July 1st and runs through the end of June, and so much of this activity was happening in the fourth quarter of our fiscal year. And as I think about our revenue streams, they really come in four different places. So in the Danforth schools, the 6 schools on the Danforth campus, our primary revenue is tuition and endowment payout. And each school runs its own business. They're responsible for their own finances, and they need to take in more money than they spend. Of course, another unit is the medical school. A primary revenue source in the medical school is patient care through our faculty practice and through research grants. We have a part of the university called the Central Fiscal Unit, which is paid for basically by taxes. We tax the schools, and the Central Fiscal Unit provides all central services, so IT and HR and all of those sorts of things. It turns out my office lives in the Central Fiscal Unit. And then finally, we have these things called auxiliaries. Auxiliaries are related businesses that the university runs. And so the dormitories, dining, the bookstore, parking, all of these things are auxiliary enterprises. And in an ideal world, those auxiliaries pay for themselves. They break even over time. Now, COVID couldn't have been timed any worse for the Washington University budget process. So we begin a process usually in about November that leads into a planning process that concludes by early March. Those budgets then go on to committees of the board and ultimately gets approved by the Board of Trustees in the May meeting. Well, we had to take those budgets and throw them away and start our budget process over again in April. Now, if you look at higher education more generally, different colleges and universities are in very different situations. So there's a huge difference in terms of university finances of whether you have a medical school or not, right? I'm going to share what was happening in terms of our clinical revenue on the medical campus. We have a quite successful and very large medical school. So we were going to be losing some clinical revenue. Not true for universities that don't have a faculty practice. For the academic units that are tuition dependent, things weren't going to be so bad for fiscal year 20 because we were just completing the academic year, but most of the challenges were going to come in fiscal 21. I love our Division III athletic program. We have one of the best athletic programs in Division III. If we had a Division I athletic program, we would have been losing money in the order well over $100 million in revenue if we were participating in one of these big conferences. So in April, we posited our values, we threw away our budgets, and we began a process to not only make some financial adjustments in the very near term, because we were having some very significant shortfalls at the medical school, but also to plan for the fiscal year that began on July 1st. So beginning in April, we were down to seeing just about 60% fewer patients than we were normally seeing. Nothing was happening electively. And we had projected at that time that we were going to lose about $150 million in revenue on the medical campus just for the end of the fiscal year, for the last quarter of fiscal year 20. There was also a lot of one-time costs on the Danforth campus, like that pack and ship operation, increased financial aid, the fact that we refunded all of our room and board charges for the last half of the semester. So about a one-time cost of $25 million. So all in, we had, just for fiscal year 20, the fiscal year we were operating under, we were going to be down $175 million. Now, to put that in context, the total university budget for fiscal year 20 was $3.6 billion, right? So on a percentage basis, it's not a lot of money, but $175 million is a lot of money. Of that, $2.6 billion is the medical school, right? So the medical school is just over 2/3 of the total university budget. So we had to make some moves in April. We did the hiring freeze, as we mentioned before. That hiring freeze has been lifted on the medical campus. Will be lifted on October 1st, and I suspect it will lift on the Danforth campus at some point in the next 3 to 6 months. No merit increases, and in fact, at the medical school, many of our faculty colleagues took reductions in base compensation and in their incentive compensation. University leadership took between 10 and 20% pay reductions. We also, unfortunately, furloughed 2,000 employees across both campuses. We were able to, because of the CARES Act, many of those folks who were furloughed didn't suffer financial consequences of being furloughed, but still lots of difficult conversations with lots of employees, including some in my office. I'm really pleased to report that 90% of those individuals were recalled at the end of July. And as I mentioned before, compensation reductions for faculty and staff over at the medical school. Then we needed to begin preparing our budgets. So we were planning, and the budget that we had initially approved for fiscal year, we were going to take for approval for fiscal 21, was showing $3.9 billion in revenue. Based on projections for what was going to happen over here on the Danforth campus and what was going to happen at the medical school, is that we had to rebudget to $3.4 billion in revenue. And so what we had to do is we had to reduce our expenses by $500 million. And we would do that in two different ways. $350 million in cuts, painful but necessary cuts. We suspended the retirement contribution for all employees, did lots of programmatic cuts. I made sure that the cuts in the central fiscal unit were deeper than the cuts in the academic units, because the academic units is really where our mission lies. We also had significant cash reserves, and so we deployed $150 million of our cash reserves. These are rainy day funds that are held by the schools and the departments. And we continue to track diligently on what's happening in the budget. Because our undergraduates didn't enroll until mid-September, as I sit here today, we still don't know exactly what the budgets are looking like on the Danforth campus as I sit here right now. We also are going to have a significant set of one-time expenses for this academic year on the Danforth campus. For those of you who have been near the campus, we have these really large and very expensive tents that are all over the place for our students to be able to study in and so forth. That takes money that was not budgeted. Our dormitories are at 2/3 capacity, so lots of revenue that we had expected in those auxiliary units we're just not seeing. So April was about the budget. The other thing that April was about was the fall. And so we needed to begin to plan for what was going to happen on the fall. And we very quickly stood up a planning committee. Dr. Lawrence was involved in it for us to put together a comprehensive plan for what we were going to do on the Danforth campus come fall. So maybe Dr. Lawrence can maybe speak a little bit about the medical side of things and your involvement as we began to plan what was going to be happening here at Washougalin and the rest of the Danforth schools.
Absolutely, it goes back to the values. What the first value was safety for all, and we certainly, felt that that was going to be the most important aspect to build. We built a public health guidelines that would be used to then, as a blueprint for all of the plans for the academic spaces, for extracurricular activities, to be able to then use that as the touchstone by which we were going to try to keep everybody as safe as possible. And the part of that was really the idea to start a little bit later, to open up the campus a little bit later, start the semester a little bit later, to be able to buy some time, partly to get our monitoring, all of our monitoring plans in place that we've been working with the health department to make sure that we have the capability to be able to do that. Also to gradually bring people back so that we can really try to get to that underlying principle of having as few people on campus close together as we can reasonably get away with and still try to give the best experience as possible. And so this idea of de-densification was a very important aspect of it and can be achieved by a gradual return to campus of both the faculty and staff, but then students as well. And that and a little bit later start also gives us an opportunity to then, would give us an opportunity to see what other schools' experiences would be and what lessons we could learn from their early opening experiences. And so, and then it really also bought more time for us to complete the developmental process of one of the really important aspects of our plan is a saliva test that was developed at the medical school that has allowed us to be able to do more comprehensive testing of students upon their return. And it was a race against time to be able to have that approved, in which, that extra couple of weeks to start the semester was able to allow that test to be ready to deploy as soon as students started showing up on campus.
Yeah, so as I think back to April, we were, there was all the work, the budget project was being worked on. And then we stood up a fall planning committee. This was a committee that was led by Marion Crane, our interim provost at the time, who passed the baton to Beverly Windland, our new provost, who started with us on July 1st. And what this planning committee did was to take those principles and to take the operational reality and to tap the expertise on our campuses. And I think that this is the thing that led us to the really strong, robust plan that we were able to release on July 31st. We had over 150 members of our community, faculty and staff from both campuses, who were working on everything: housing, dining, the academic experience, public health monitoring, testing, every one of our spaces on campus, and using their academic expertise, using their professional expertise for us to get this right. We engaged our community very intentionally through a series of town halls and so forth to get as much information as we could, and that ultimately led to the plan that we published. We published that plan on July 31st. As Dr. Lawrence mentioned, the later start to our academic year has served us very well. Not only did it give us more time operationally, or more time for our faculty to prepare for hybrid instruction for the courses that would be offered in person and online, but also the opportunity to look at other campuses and to learn from them. One of the things that I think may be true, I don't know, it's a hypothesis at this point. I'm not sure if we're ever going to be able to see if the hypothesis is true or not. I do think there was another advantage to us starting later. And that is our students and members of our community could see what was happening on other campuses, and seeing what the consequences were if folks didn't follow our public health guidelines. Seeing what was happening in Notre Dame and North Carolina, Michigan State, and other campuses. And I think, as effective as we could be in terms of a public health campaign, which we have stood up and we are continuing every day on the campus, that only goes so far. And I think for our community to look and say, oh, if we don't abide by these guidelines, if we don't follow these rules, if we don't use the spaces in healthy ways that they're being designed for, that things could get pretty bad. And I think that having the opportunity to see that in reality at other campuses beginning in the middle of August and carrying through early September, I think is something that's really given us a leg up in terms of our ability to be successful this semester. This is Tuesday of week 3 in terms of our undergraduate programs. We are in week 6 of programs at the Brown School and the Law School. And knock on wood, so far things are going really extraordinarily well. And it's an important partnership. Right? It's a partnership between the university and its administration, which owes our community testing and contact tracing and safe spaces and places to eat and sleep and all of study and all of those sorts of things. But it's also a responsibility of every member of our community to follow best practices, to mask, to practice social distancing, good hand hygiene, and not gather in large crowds. And so far, I'm seeing our community really pulling together in extraordinary ways. The university is delivering, our students, faculty, and staff are delivering, and that gives me measured optimism for the rest of this semester and next semester as well. So Dr. Lawrence, maybe you could share your perspective about what's happening on the campus. But I know that there's lots of folks who are really interested in the research that's happening at the medical school, how you see this pandemic playing out, particularly with vaccines perhaps on the horizon. Now's your time to profess, Professor.
Well, first, I just want to say, though, too, I think, you were so right about the advantages of having that time and the experiences, so people knew what coming onto campus might be like, and how necessary it was to be able to focus on some of those very, very core principles that we put together for keeping people safe. So universal masking, keeping physical distance, and configuring spaces to be able to do that. We knew that it would take a culture change. It's not just listing off of things to do and then just throwing it at and say everybody needs to do this. It's actually creating a culture to be able to make those measures successful. And the time, certainly the timing that was part of it, but then also all of the work that all of the committees had done to prepare for it. Really, I am pleasantly surprised and cautiously optimistic, as you are, Chancellor Martin, that the start has been is been good so far. And from the we obviously can't run a victory lap now, but we certainly. I do believe that the attempts to change culture have been successful, at least as successful or more so than I would have even anticipated. Now, what's on the medical school campus, we are doing certainly a lot of activities. Much of the research that is taking place right now, and certainly all of the research that was taking place during the lockdown periods, were really around COVID-19. And it ranges the entire from basic science to understand the mechanisms of how the virus works, building the animal models, and say Mike Diamond's lab, who's been able to understand the immunology of the virus and how it causes disease, how the body's immune system responds to it, and the models that other laboratories across the world are using to be able to put their expertise to use to try to answer some of these critical questions in this brand new virus. Remember that nobody had ever seen before December of 2019. And then there are the clinical studies that there are many of them ongoing. So including treatment trials. We had one of the investigators that was at the lead of convalescent plasma, taking the antibodies from people who recovered from disease to be able to then use them to give to other people. This is a century-old technology, but still one that does have some benefit. And some of the leading thought on that was done at our campus. In addition, we are one of the sites for the early vaccine trials that are currently ongoing. Two of the vaccine products have been slated to come through our clinical trials unit, and we work really hand in hand in collaboration with SLU to be able to maximize our region's ability to contribute to recruiting patients into the phase 3 studies for the vaccines that are being developed. And, these are certainly, we're also looking at other unique ways. There's a measles or MMR vaccine study that is being done here as well to be able to determine if, the really interesting thing that this virus, there's some evidence that if you even give a vaccine to something else, it revs up your immune system to be able to provide some non-specific immunity that would protect versus COVID-19. And that study is also, we're one of the lead sites for it as well. And so there are many, many other things that are being done, and certainly adding to it every day. One of the other ones from a public health perspective, helping our health department partners in determining what the seroprevalence is, or the number or proportion of people who are infected here in the St. Louis region. And that study is just finishing up as well. And so a lot of exciting things happening on the medical school campus. We're trying to maintain our position as leaders in both infectious disease and medicine and medical research around the world. And I think that we're really trying to live up to that.
Well, thank you for sharing that, Dr. Lawrence, and thank you for your leadership on both of our campuses and in our community during this really fraught time. I mean, I think that really gets us caught up to where we are today. I mean, we are a university that, given the constraint of COVID-19, is doing everything we possibly can to fulfill our mission, our educational mission, the research mission, and our patient care mission. And it looks very different. The classroom experience on the Danforth campus is very different. Our clinical operations on the medical campus are different than they were a year ago. But even with COVID-19, we're able to continue to serve our mission for the greater good to the greatest extent possible. So I'm going to turn things over to Dean Taylor to help moderate some questions from all of you. I do want you all to know that Dean Taylor and the leadership team at WashU Olin have really done an extraordinary job leveraging all of the assets of the school for all of the different education programs at WashU Olin to be able to continue this important work. Even during these times. And for a business school as ours that is so well positioned internationally, that's been particularly challenging. But Dean Taylor and the team have really done a very strong work to continue the good work of WashU Olin in these front times. So Dean Taylor, congratulations to you and your folks for all of the work that's been done over these last 6-7 months. And I think Dr. Lawrence and I are ready for questions.
Thank you, Chancellor. Thank you for those kind words, and thank you, of course, for your leadership of the university during this time. And thank you, Steve. Steve's been a great source of information for the school on a number of occasions, and that's really, I think, that transparency that we spoke of as being a two-way process, and so really keeping us abreast of developments and exactly how this epidemiology works in this environment has been very, very important as well. In fact, one of the questions I have, is the first question that's come in is directed at you, I think, Dr. Lawrence, which says, do you anticipate another wave during the fall/winter flu season?
Well, I think it's always treacherous to try to make predictions with the respiratory viruses, and this one is no exception. But we do have concern that there will be an increase in activity when it gets colder. That is something that we have a couple of reasons to believe it. One of them is that even though there hasn't been a determined strong seasonality to this virus yet, like we've seen with influenza, because we don't ever see flu in the summer, right? It's only during the winter. It's a seasonal virus. Coronaviruses, the milder cousins of our current COVID, do have a seasonal aspect. And we do have some expectation that this virus, because we know it lives longer in cold, dry conditions, probably will be worse in winter months. But the reason, it's still going on in the summer is just, again, because there are so many people that are susceptible to it that it can still find people to infect, even when the conditions aren't right for it to exist for long periods of time. So one of these is there is probably some reason to believe that there may be some worsening from the weather patterns and the seasonality of it. But the other thing is, of course, a great concern is if we have a dual pandemic or a dual epidemic of flu at the same time. Some flu seasons, you might recall, can be terrible. Like we've had some in 2007 and 08, 13 and 14, for example, even 09 and 10 with the pandemic and H1N1 flu, is that they themselves can sometimes max out a healthcare system. And if in a worst case scenario, we have another surge of COVID and flu, a bad flu season at the same time, we could really be in trouble. And so this is one of the reasons why we have been encouraging and imploring and frankly, almost begging everybody to get a flu shot this year. And anything we can do to reduce the possibility of these two things simultaneously affecting large swaths of the population at the same time, we want to do everything we can to prevent that.
Yeah, and there is a question about that, and you kind of answered it, which is if we're working at home, is a flu shot just as important as if we're coming in on campus?
Well, I think it really depends on, the amount of interactions in public. We do know that influenza spreads essentially the same way that COVID does. And so the risk of flu luckily also decreases. One of the things that we are cautiously optimistic about, while we're very concerned about the possibility of peak activity of both at the same time, but we're also have a little bit of optimism based on, say, for example, what's happened in the Southern Hemisphere and what we saw back in March during the stay-at-home orders, and that was at the tail end of the flu season, and we saw flu essentially disappear. And Australia had a very, very mild flu season, and we think it's because all of these measures that we're doing right now with universal masking, keeping distances, avoiding large gatherings, all of these things we think can keep the flu season at bay as well. But the vaccine is still really important because we can't just count on those. We need to do everything that we can to try to minimize that chance. So I would even recommend people staying at home to get the flu vaccine too. Thank you.
Another question really is the kind of, I guess, how can we encapsulate some of the discussion that we've had about how the university has proceeded during this crisis? And the question is this. We've had quite a small number of cases amongst quite a large number of students, which is different from what we've seen on a number of other campuses. So how would we, in summary, what would we say that we've done differently? What has WashU done differently from other universities that have allowed that relative success up to this point?
Well, maybe I'll start, Steve, and you can finish. I have a couple of hypotheses from the university perspective, and Dr. Lawrence can talk about it from the public health perspective. I think there are a couple of things that we've done that are affording us some great advantages. And so one is that we really tapped the expertise of our faculty from all 7 schools and our professional staff from all 7 schools to help us solve a lot of really thorny problems. How are you best going to utilize this lecture hall? How are you going to redesign your dining facilities? All of these things. And we were able to leverage that expertise and do this in a very comprehensive and consultative way. Places that had to plan very quickly weren't able to do it, I think, at the level of specificity that we were able to. Second thing is the late start. I made that decision about the late start very early. It was of all the decisions that were made, other than the shutting down the Danforth campus in the middle of March, the most controversial decision at the time. But it was the right decision at the time because it gave us much time to adapt. Everybody was worried about the second surge of COVID that was going to happen in November or December. Well, we now know that the second surge we saw in July, and who knows what the third and the fourth or fifth surge may look like. And so buying time, I think, has been really valuable. And the hypothesis that I stated about our students and faculty and staff being able to see what was happening on other campuses, I think that's improved the efficacy of the really strong public health campaign that we were able to put together. Dr. Lawrence, what are your hypotheses?
Oh, they're almost exactly the same. And I think there are a few things. One of them is the culture that was created, that we had hoped to create, I think has come to fruition, and that there is a culture on campus to take these measures very, very seriously of universal masking, physical distancing, and avoiding gatherings. And that has really set in. So we have to give a lot of credit to our students and our faculty and our staff who take these things seriously. And we have, while we don't have the data for it, I think it's not a stretch to be able to hypothesize that our students have done a better job than many other universities in avoiding the big party types of scenarios that lead to the big clusters. And certainly we're certain some of that has happened, but that we don't think that it's at the same extent, because those are what can cause super spreading events. But there's one other factor too that I think we can't completely overlook, and one of them is luck. Because we've been fortunate. There are other universities who have done, I think, just as good of a job as we have, and have had one or two events of just parties get together and they have what's called a super spreader event, where one person can spread to 20 or 30 others, and then those lead to secondary cases, and that's enough to really put a big damper on it. And so it's a combination of hard work, good structure, culture, working by principles, and then a little bit of luck.
Thank you. So we've had several questions about testing, particularly of surveillance testing of students, and we're kind of testing every other week. And questions are really what made you decide on that frequency? Is it enough to test every other week, one every week, or more frequently?
I would love to be able to pass that one to Chancellor Martin. All right, I'll go ahead and take this one. This actually is the number one question that we've had throughout the reopening process, is about the testing strategy. And so I think it's important to say, first and foremost, the most important part of the testing strategy is to be able to have the capacity to do what's called diagnostic testing. And this is where people who have symptoms, who show that they're sick, these are the people who are most likely to spread to others and cause big outbreaks. That we have the capacity to identify all of those, to be able to test every person with those symptoms, and we have done that. The next part was the idea of entry testing, and that was possible through the creation of this new saliva test that just had been approved by the FDA for emergency use, and that our campus created. And so that gave us the extra assurance that how many people are coming in with infection, and it was incredibly low. So 0.1% of people who were coming in, students that were coming in, brought infection with them when they came in. And then the other part of the testing, which has gotten the most attention, is what's called surveillance testing, is when it's done on a repeated fashion. And quite frankly, there are no data, nobody knows the right frequency to do this. And the truth is, it probably depends how frequently you need to do it, probably depends on how much activity there is on campus. And at the moment, we have started, with a choice of every 2 weeks to be able to have sort of a rational approach that's logistically feasible, and one that would still be able to reasonably catch early clusters. And the capacity, if we need it, if, for example, transmission rates are dramatically up, there are clusters that we can't identify where they're coming from, and we need to do broader testing, we can deploy that if we need to. But at the moment, there's no indication at the moment that the frequency of every 2 weeks would need to be modified.
Thank you. I think the next question is directed primarily at the Chancellor. It says, making values central to decision making is impressive, and creating and changing culture is a lofty and necessary goal in order to succeed. So, how did you determine who the core team members needed to be when you developed your response to the crisis?
So that's that is a great question, and I'd love to provide a very elegant, well thought out response. But in actuality, that's not how it played out. And so there were really two different aspects. I mean, one, for the senior university leadership, there's a group that I began convening when I became chancellor. 8 or 9 people sit on that group, the most senior university leaders, and that's a group that, particularly for a lot of these values, were the group that I was relying on. Include the provost, the dean of the medical school, our chief financial officer, chief administrative officer. That was sort of my team in the chancellor's office. Frankly, the more important groups, particularly the groups that we stood up in February and in March, we brought whatever expertise that we needed. So we needed to stand up a group for the Danforth campus to deal with everything from HR and finances to our educational mission and whatnot. And we very quickly just cast about and said, who are the right people to make, to do this? Talk to the provost. Which are the deans that we needed to involve in this? What are the right undergraduate, associate deans, and the like? And on both campuses, we made sure we had medical expertise. Thankfully, I had the opportunity to meet Dr. Lawrence very early in this pandemic. He certainly recommended by the dean of the medical school, and Dr. Lawrence was really embedded with what we were doing here on the Danforth campus, as were colleagues on the medical campus as well. So in those early days was really, what is the expertise that we need? I mean, one of the things that we really needed a lot of help on both campuses had to do with supply chains and logistics. We needed to get a bunch of stuff. And so, we were relying on the administrative teams in that area. It was really, what are the skill sets that people could bring for what we needed at the time? The fall planning process, and you, Dean Taylor, were on the executive committee that designed that process and ultimately did it. That was a much more rational, well thought out process for who to involve in what decisions. And the reason why is because we had great leadership from that executive committee, but we also had the gift of time. We did not have the gift of time in March. It was really all hands on deck. And so, what it meant from an operational standpoint is we were having these meetings, I think it was at 7:30 or 8 every morning, the emergency response, and there were probably too many people in those meetings. But it was necessary to have, we just had to get all hands on deck to be able to manage. Once we got to April, once we were able to turn to the fall, that the medical school had done all of its planning, and so then it was really about how do you practice medicine and do research in this very constrained environment, and we could focus on the budget. That allowed us to be a little bit more thoughtful and rational in terms of how we pulled all those things together.
Thank you, Chancellor. The next question is directed at Dr. Lawrence and your expertise on vaccines in particular, and the vaccine or vaccines that are being developed. Can you talk a little bit about the COVID vaccine or vaccines and their use for children and people with underlying health conditions? And will the vaccine or vaccines, once approved, be safe for those populations in particular, young people and underlying health conditions?
Yeah, sure. So the short answer is that the trials actually are not focused that much on children, and there's both there's a good reason for that, but then also it is a deficiency in where that we're looking at. First, the good reason is that for young children in particular, especially below the age of 10, there is a lower chance of infection and less severe disease. And so it's really actually quite rare for kids to get particularly ill from COVID-19. And unlike flu, where children are the reservoir of disease during an outbreak, it seems to be the other way around for COVID-19, in that mostly adults are the reservoir. The idea is eventually that the priorities will include children in the clinical trials, but right now the focus is trying to include in the trials and to prove efficacy and safety in the highest risk patients, those who are at the highest risk of complications. By far and away, the number one risk factor for severe disease is age. Once we start seeing age 60 and over, we see an almost linear increase in the rate of hospitalization and death. And so the trials are very focused on trying to make sure that there's a representative proportion of patients over 60, but then also other health conditions as well. And the hope is that the clinical trials will include enough people with underlying health conditions to prove that it both does provide protection in those, but then also doesn't have any untoward side effects.
So thank you for that reply. So one, let me think about is during this time, I've been spending my extra hours reading some of the diaries of Samuel Pepys, who was a 17th century Londoner who's he wrote private diaries, which are actually wonderful, and they were discovered and they're part of English literature, although he wrote them really for no one to read. But the interesting entries are for the years 1665 and 1666. 1665 was the last great plague of London, and the bubonic plague was far more deadly than even COVID-19. And 1666 was the Great Fire of London, when virtually the whole of London burnt down after a fire was started in a baker's shop in Pudding Lane. Now, what strikes me is that we have not found a vaccine, really, for the bubonic plague. Correct me if I'm wrong. And also, we still have fire, but we don't get the plague, and cities don't burn down with the regularity they did in the 17th century. And I guess the reason that doesn't happen is we changed our behavior. Right, personal hygiene, public hygiene changed dramatically, largely in response to plague outbreaks, and we don't have fires because we have a standing fire service, and we don't build houses of wood right next to bakers' shops anymore. Right, we have fire and safety regulation with a standing fire service. And is it the case that this will permanently change behavior going forward, and that COVID, will always be with us to some extent?
Yeah, for the first part, yeah, I think it will change behavior, and that there will be a new normal. I really don't foresee that life exactly as we saw it before is going to be the same. And first, we're definitely going to have COVID with us. It is part of it's become endemic, and it will likely be a seasonal thing that we see with flu, and that likely over time the severity attenuates and herd immunity increases, so that there won't be the massive effects on the population within another year or two. But I think there are going to be some permanent changes, and I'd be curious to see what Chancellor Martin would think too about some of the changes. Like, are we going to continue having Zoom meetings and business? And you too, Dean Taylor, about what do you guys think that we're going to end up? Business is going to be completely different in the future.
I think higher education is certainly going to be different. I do think that one of the things that's really been highlighted, and this is true for any student who had to experience what happened in the second half of the spring semester, whether in high school, K-12, or in university settings, is that what we're able to do at Washington University is really extraordinary, and the demand for particularly for undergraduate in-person education, I think, is going to be even more going forward than it has been at the past. That's a good thing. But I think the way that we use technology, the way that we structure our time, the amount that we travel, are all going to be profoundly different post-pandemic. I think the other thing, which is just going to be interesting to see how this plays out, has to do with our physical spaces. I mean, we have wonderful buildings. Every faculty member has a great office. We have lots of folks who work on the campus who needn't work on the campus. And so the question is, and it's not as, okay, how much space can we wring out of the system? That's not what we want to do, although freeing up space is going to create new space that we can use for other things, whether for the student experience or increased research or whatnot. I mean, there's lots of of interesting things that we can do. But the question is, I think, not so much how much space can you claw back, how can you preserve a culture of community and collaboration and togetherness and esprit de corps and everything else that happens in an office setting? How do you achieve that in a world in which some employees, some of the time from now on, are not going to have to be in the office from 8 to 5? And I think that's going to really be a big challenge. It's going to be a big challenge for every organization, but I think higher education in particular, because of the spaces that we've built to a particular model, and I think that model is going to change.
Yeah, and just a quick plug for the business school. We are actually thinking deeply about these issues right now. And you're right, Chancellor, this will change higher education, but it will also change business. What does it mean to be global in this post-pandemic world, for example? We currently have 2 task forces thinking, what will the nature of business education look like post-pandemic, and we're determined that we'll be at the forefront of that. So here's another technical one for Dr. Lawrence. It's a long question, but the pith of it is, why is it so difficult to get tested? Why can't everybody be tested so we know what the infection rate is? Yeah?
Well, so there's a very complex answer to that question. But one of the early days, part of it was a lack of ability to test and the capacity and just the sheer numbers that we would be needed to find all of the cases. But the other and now more pertinent answer to the question is, when we're talking about testing, you want to answer the question, why do you test? And so we have to prioritize where we're using tests and for what reason. So for an institution, for a public health agency, for a hospital, for the medical, the medical providers, diagnostic testing is by far and away the most important thing that needs to be done. And we need to ensure that the capacity we have as a society can support the diagnostic testing. We need to know when people are sick with this for 2 reasons, so that then they can be treated if needed for it when it's necessary. And they're the most contagious. They're the ones that are going to go and spread the big outbreaks, and they're more likely to infect other people. The other, and then there's the aspect of when to use testing for people without symptoms. And that is a much, much more complex societal and sort of public health question. Certainly, if those who have been exposed have had close exposure, and you want to be able to identify somebody who has infection before they show symptoms, for the sole purpose then of being able to start a new chain of contact tracing. So from a public health measure, there is some advantage if you have widespread availability of testing to be able to do asymptomatic testing. But one thing that for those people who just want to know, there's not a lot of value in an individual knowing if they have infection or not at the moment when we are living under conditions that are completely designed to prevent asymptomatic spread by universal masking and physical distancing and avoiding gatherings. We actually are operating right now with the assumption that every person is infected all of the time. And when we do that, we can keep transmission down to lower levels. But for one individual without symptoms, the knowledge of whether I have infection or not is interesting, and some people may want to know that. But to keep in mind, sometimes the test is wrong. And so if it would then lead to higher risk behaviors where there's no masking and distancing, it actually could then backfire and cause negative impact on it. And then also, it's only that moment in time. It doesn't say then if you then have infection the next day or 2 days down the road.
The next question is about community outreach. Is there anything we can do, could do, plan to do that helps educate the public on the severity of the pandemic, especially amongst people that might not believe or understand the importance of mask wearing, social distancing, and so forth?
I think it'd be great, Dr. Lawrence, if you could talk about the pandemic task force and the work that's been done here in St. Louis to address that problem straight on.
Yeah, sure. So then, this was mentioned earlier, in that we are part of the pandemic task force, which are health systems and the health departments and the medical community, the universities working together to be able to partly educate and to be able to have our region understand the importance of these measures, which I think our region is a little better prepared for and understands, the immediate region in particular, understands those measures, the importance of them, how these mitigation strategies work, and how effective they are. So I think that there is, some advantage to having a cohesive, coordinated messaging that is on task and on target. But one thing that I think has been the challenge, a big challenge globally with this is, and particularly in this country, is that there are different belief systems that go beyond just science and public health, and that and we don't always win the narrative. We are not always the best at being able to make a convincing argument that this is what's important and why, in certain people. And so it is just an ongoing challenge, and one that we just have to continue to show examples of how it's working, and to be able to provide the convincing narrative so that it is it's one that captures imagination and captures the sort of the will of people to be able to put that together, that these measures can be safe and stop disease, slow it down, diminish the impact, without necessarily having complete economic shutdowns to do that. We can do these other measures without having to shut things down completely.
So this next question is a really a technical one. It's asking you, Dr. Lawrence, if you could speculate or think about, if you're advising a local school board, what kind of metric might you use, where we are on the curve or positivity rate or whatever, before you'd feel reasonably, we'd feel comfortable with advising the school to bring children back in person 100%.
Yeah.
Full density.
Some of the metrics really are the community spread in kids in particular, how many cases per 100,000 that are occurring in young children. Also the test positivity rate. Those are the two major metrics that we look at, not only for schools, but that we do for our own monitoring for the Danforth campus and our own region. But the other thing that, at the moment, it is safe for kids to be in school, especially the younger ones. Below 6th grade and below, and there's a lot of empirical evidence to show that there are already thousands of kids in school right now. And so far, after a month of, several thousand kids in school in some of the independent schools and some of the some school districts, to date, there has not yet been a single episode of transmission between kids or between faculty and students in the school setting. And so we know what can be done to keep things safe. That's what led us to be very confident on the Danforth campus, for example, to say, if we put these measures in place and we can change the culture to really enforce and to have everybody believe in the importance of these measures, we can not quite guarantee, but have a very strong sense that transmission will not occur on campus. It will not occur in the classrooms or during curricular activities. And so the real key then is just what is happening outside of those that we need to have our eyes on.
I think there's a question for the Chancellor. So Chancellor, what is the outlook on getting international students actually back on campus, and how do we keep them engaged in the interim?
I think that's a great question, and it's a question that's really it's frankly a question of public policy that are outside of the control of the university. I think many of the constraints that our international students are facing are being driven by the federal government, with ever-changing regulations and visa requirements and everything else. And so I think it's really unfortunate that we're not operating in an environment where universities can have certainty and our students can have certainty about how the process is going to play out. I think that's one of the things that's really been most difficult for our international students. I mean, in terms of keeping them engaged, we really need to rely on our academic leaders of each of our programs, like you, Dean Taylor, to ensure that we're doing all the right things to support our students. And one of the things that I know is happening at WashU Olin and in other parts of the university as well is that we're mindful that many of our international students are in time zones that don't sync up so well in terms of the central time zone in the United States, right? And so we're doing education, we're doing engagement early in the morning, late at night, in order to be able to keep that community. We're doing creative things with the academic calendar to give our programs the greatest sense of success. But this is really hard work, and I'm hopeful that we'll be in a situation very soon that we'll have knowledge about what student visas will look like, what's possible in terms of travel and so forth, so we can work within those constraints. But as you know, it's been a very dynamic environment really over the last 5 or 6 months, and I don't expect that changing anytime soon.
And just to amplify that, we are thinking what it is to be global. Well, part of being a global business school is being global friendly and offering courses that are not at 4 a.m. in parts of the world where you're teaching. So as you said, Chancellor, we in the business school faculty are teaching courses starting at 5:30 a.m. St. Louis time and right up till around about midnight St. Louis time as well. And some of that will continue, right, as we go into this new normal, and we think what it means to be a global business school. Now, another question here it's actually from Albert Ipp, a great friend of the school.
Oh, wonderful.
And Albert says, with COVID and other factors, how do you, Chancellor, see the collaboration with our academic partners around the world going forward, both for existing, possibly future collaboration?
I think it presents some real opportunities and some real challenges. Certainly in the short term, and I hope it's just in the short term, I think collaboration and educational programs are going to be more difficult because an important part of collaboration is, at least to some extent, being able to gather physically in a space and work together. And I think that there are some opportunities to innovate, but some of the programs that we're running in person with our faculty, particularly, of course, the executive MBA program that have been running in Shanghai, I think is going to be complicated, at least in the short term. I think the place where we have the greatest opportunity is in research. Is that I think that 5 years from now, 50 years from now, I'm hopeful that we look back at 2020 and the scientific response, the global scientific response that was led in academia in partnership with industry to develop vaccines, to do research about therapeutics and everything else, will be viewed as a greater scientific achievement than anything that we've done before. And you can sort of look at the progress that we've made just at our medical school and the hundreds of faculty colleagues who dropped other lines of research to be able to do basic research, translational research, clinical trials research is all so very important. And so as I think about the scientific collaborations in particular, that this is a real opportunity for us, not as a nation, but as a globe, to really focus on some of the really challenging problems. I think health disparity, which is something that's playing out here in the United States, but is also playing out around the globe, is going to be something which is going to be uniquely poised for international collaboration right now. And of course, sort of stating the obvious, viruses don't respect international borders, right? We are living in a global political economy with all sorts of connections. And so as we think about the changing nature of business, I think research in terms of supply chains is going to become very sexy once again because of everything that we've experienced over these last 6 months. The practice of law is going to fundamentally change. Of course, the discipline of public health, which has always been so important, is going to become ever more important. That those are some really great opportunities for our faculty around the globe to be working with one another on facing down some of these really significant problems. I think future there is very bright. I think educational collaboration is going to be a lot more challenging.
Thank you, Chancellor. Well, we're coming to the end of our time together, and really remains for me to thank Chancellor, Dr. Lawrence. Thank you so much for being with us this evening, and we hope that the audience have enjoyed the great insights and know that the university is in great hands. So thank you both. Before
you,
we
Taylor.
leave, before we go, could you please note the slides now rolling on your screen? If you're interested in engaging with Olin through any of the following offices, we encourage you to capture the contact information if you can catch it, and reach out to Ruthie Piles in graduate programs, or Dorothy Kittner in corporate engagement, Office of Business Development, Jennifer Witten at the Careers Center, Sean Martin, Olin Advancement, or Michelle Ralston in executive development. So that concludes our program for this evening. We look forward to seeing you at our next Leadership Perspectives event in October 15th, where we will host WashU alum Michael Weiss and WashU alum Marcus Jecklin, who will discuss artificial intelligence and the future of human-machine collaboration. In the meantime, stay safe and be well. Have a great evening.